I'm now one of a team at Breakspear, and so I'm going to present some of the work from all of us. So I'd like to thank the organisers here for inviting me to represent all of these people who work with me and some of their findings to you all, and thank you for the invitation. So Dr. Damon, just to put you in the picture, he's a rheumatologist, but he has been dealing with Lyme patients a lot. Dr. Yo is a physician who's very experienced now, and she's also a nutrition degree. And Mr. Leon is a nutritionist. Peter Julu is an autonomic neurophysiologist. Dr. Jamal is a consultant physician, a neurologist and clinical neurophysiologist. And they have an assistant who's an electroencephalography specialist. So this is our team, but we have a small hospital. And I have to say, I'm very sorry, it is private. We keep trying to get funding for people and to get health authorities and insurance companies to pay, and we'll do our best for people with whatever we can for them, with whatever their state. So this is the title, of course, for the conference, and we follow the same pattern as others in looking at the case definition, but I've particularly emphasized that some of these symptoms are the things we look at as clinicians: the fatigue, the autonomic manifestations, sleep dysfunction, pain, and so on, and the immune manifestations. And I've taken the liberty here of illustrating for you what sorts of factors we consider in our patients, because we consider multifactorial things. And just to show you this, I've given it to you as a handout because I might refer to it again from time to time. And of course, the two primary things people need are food and oxygen, obviously. And very simplistically, the food, protein, fat, carbohydrates are broken down by both anaerobic and aerobic metabolism. And we know that the anaerobic metabolism, unfortunately, predominates sometimes, though it's necessary in acute situations. Oxygen, carbon dioxide levels, coagulation studies, acidosis, these are all features that we look at. We look at cellular integrity, the cell walls and pollutants that people have, infections, and we look at gastrointestinal function. All of these in our patients, amongst other things, but that's to illustrate some of the investigations we might do. And we look at the organic acid test because this tells us how we're breaking down food quite helpfully, and ATP profiles. I think last year Dr. Myhill was talking about the ATP profiles and how she looks at those. But we also are very interested in the fact that fructose, when it's broken down, can produce lactic acid. And so we're very concerned that this may be one of the factors that people are having to face now, because it is used as an enrichment in many soft drinks and quick foods. Then we look at transcutaneous gases. And this isn't the blood gases from the arteries and the venules, but transcutaneous gases. And we've got particular autonomic tests, which we call the quantitative inotropic fatigue tests. We're also looking at sleep, because that's one of the major things that is complained of. And we look at sleep studies, and we're looking at thrombin. We're looking at thrombin, antithrombin complexes in particular, which we've found to be abnormal in most of our patients. We look at cellular integrity and looking at all of these infections, and we find that, as has been said, a lot of infectious agents are present in our patients. And then we look at detox programs for people which are based on looking at their own genomic profiles. We look at gastrointestinal function, And I do think that here it's extremely important to see how these all integrate, because for the best outcome for our patients, we have to look at all sorts of factors simultaneously. Just to mention lactic acid, because this was one of the things that we know is produced in our patients. It's formed from pyruvate in glycolysis, and strenuous exercise, 10 to 15 times increase in it. During fasting, it's low, but it's high after meals. It's produced in low oxygen states. And so this is quite important for people, because we know that in our patients, many of them are hypoxic. We also know that lactic acid is produced by a number of different drugs and, of course, by ethanol. But you'll see that it's one of the things that's possibly produced by salicylates, which we're being told to consume regularly, and in various common disorders like diabetes. It's also produced in the gut when people have an overgrowth of bacteria in the gut. And it's produced as a result of fructose metabolism. So just to emphasize for you the Krebs cycle, which is the energy cycle, this is our preferred way of producing energy in the body. We go from A to B all around this, in citrate all the way around this cycle. And we use fats for this cycle, and it is the aerobic cycle. So where you look at food, protein and fat, it comes down here and into this cycle. And wherever you see E, this is a little simplified cycle, we're producing energy. So this is our preferred way of producing energy. If, however, we can't do it, then we use that, which is the anaerobic one. And part of the product of that, as I said before, is lactic acid, which makes for acidic tissues. I think it's quite important to know that with a simple urine organic test, you can tell whether there are blockages in this, because B5 is used here, glutathione here, alpha-ketoglutarate acid here, coenzyme Q10 here, magnesium malate we tend to use here. Magnesium is required for a lot of processes, many of the enzyme systems. And here fructose is broken. Fructose is half of the sucrose molecule. The other half is glucose. But fructose is broken down by an enzyme called fructokinase. All kinases take magnesium as their cofactor. And it goes down here to form then intermediate products, and then by further metabolism, glucose, glycogen, lactate, and uric acid, and ATP is released. ATP stands for adenosine triphosphate, which, when it converts to ADP, releases energy. And so this is the sort of little battery that releases energy, and then it's reformed, so the battery is recharged. But the point is that fructose actually takes magnesium here, requires the ATP energy usage, and actually there's a further use of ATP in these metabolic processes. And if any of them are not working efficiently, we produce lactic acid and uric acid. And in the literature lately, they're saying that fructose-enriched drinks, 90% of some of the fizzy drinks is sweetened with fructose. It's high fructose corn syrup. And they will actually people can actually have gout from uric acid from it. But quite often they can have lactate being produced, and it is a problem. So here I just want to mention capillary circulation. The arteries and veins in between are capillaries. There are pre-capillaries here, and it's these which sort of shut off as a result of our autonomic nervous system controlling the pathways through the capillaries. And I want to emphasize that what we found is that there is a dysautonomia, which means that very likely these are shut off to a certain extent. They're irregularly shut off, and then blood flows through a different bit and so on. Ordinarily, carbon dioxide is released from the blood, oxygen is released from the blood, and CO2 is returned. So they put the arrows the wrong way. And in these little capillaries, we have to assume that the blood flow through them is going to be good, and that the little cells can get through, but they can't always. And I'll tell you why. It's because we have abnormal coagulation in some of our patients. In fact, uniformly in our patients, we have found abnormal thrombin, antithrombin complexes. They have immune complexes to viruses and to Borrelia organisms, which get stuck in the capillaries, perhaps. And we know that there are also immune complexes from foods which are circulating. So we know that the capillary circulation is impaired. And what does that do? It leads to inadequate oxygenation of the tissues, and the carbon dioxide is not taken back into the circulation. And so there's a state here of acidosis, tissue acidosis. Also, what happens when there is anoxia is that the lining of the blood vessels produces a stuff called VEGF, which is vascular endothelial growth factor. And there is a disturbance of nitric oxide and peroxynitrite as a result of the processes going on in the vasculature. And what we found also in the few patients we've just started studying is that we've got high levels of VEGF in the bloodstream of our patients. And we know, therefore, that there is this process going on. That, of course, is natural, because what we want to do with vascular endothelial growth factor is to bud off new capillaries, because they're trying to get over the fact that there's an anoxic tissue there. So we look at immune complexes, infectious agents, we look at the thrombin, antithrombin, we look at the others. Fibrin and D-dimers are not abnormal, and we've been looking at VEGF. And the treatments that we would use are low-dose immunotherapy and detox for this, all sorts of treatments for infectious agents. We use anticoagulants, natural anticoagulants quite often. We use things like nattokinase. And to clear off peroxynitrite, we use B12. The vessel damage that is occurring is from acidic extracellular pH. All of this, as I've described, angiogenesis, increased vascular permeability, which leads to more edema and less perfusion in the capillaries and more anoxic states. There are now quite a lot of drugs being formed like Lucentis and Macogen, which will actually reverse this in specific conditions like the eyes. And it may well be that this is hopeful for us here. Just to run through the autonomic nervous system, I know that this has already been very well dealt with, but just to emphasize that we know that part of this is an autonomic dysfunction. And so we've been measuring autonomic function, doing all these tests, sympathetic tests, cardiovascular reflexes. The ones I've highlighted in red here are actually ones we call our QIFT test, which is quantitative inotropic quantitative inotropic fatigue tests that we're doing. Now, I'm sorry about this, it's rather complex information, but it's done by Dr. Peter Julu, who is an expert, and he also does capillary oxygen saturation. And what these are the sympathetic function from cardioaccelerator function in the skeletal muscles. The deep targets are in the heart, in the muscles, and in the gut. And the brainstem autonomic functions we look at, And we find that looking at these resting cardiac vagal tone and the various reflexes, the baroreflex, which is from the vessels in the neck, and looking at the breathing rhythms. And these are all done non-invasively. The patient just lies there and does a few things like lifting, sitting up or holding something tight for 3 minutes or breathing deeply, or the neck is rubbed. They're very simple tests, and but it's the complex maths afterwards that matters. And the brainstem autonomic functions are looked at, therefore, and they have to be monitored continuously for a proper interpretation. The control is in the brainstem, and we look at cardiodynamics, which is contractility and isometric contraction. They're important functions of the heart, and they're used to indicate the heart is healthy. We also look at the blood gases, because autonomic function is influenced by blood gases, as well as influencing them. It's vice versa. So this is the test that we do, and what we show is that the brainstem is irritable. It's almost like epilepsy. And you can see that the vagal tone is showing this in a continuous thing. Excuse me, I won't tell you what all of these things mean. It takes a bit of more time. Also, that in every patient, we've studied now over 150 patients, there is not one that hasn't shown these abnormalities. The heart fatigues either suddenly or gradually. And here you can see this blue squiggle. This person was asked just simply to hold a thing a bit like a tuning fork and just grip the ends of it together and to hold it like that for 3 minutes. And look at the sudden fatigue that happened. When she stopped, it was a recovery. But I can tell you that in some of our children and some of our very sick patients, it'll take 2 days to recover from that much activity. So what we know is that we can measure it. It's absolutely incontrovertible. You can't say that that's not happening, or that it's been possible to reverse it by talking to the heart. Here we have gradual fatigue, and again, that's over a period of 3 minutes. So it just illustrates that there is a real demonstration that there is a sort of heart failure, but it's not the heart failure where the lungs get congested with fluid. It's the heart muscles are failing from this point of view. And also when we do partial pressure of oxygen in the capillaries, it's at asphyxia level. These people, my patients, are being strangled because they haven't got enough blood, but it's not a strangulation of the oxygen. It's not a strangulation of the supply chain. It's not the lungs. It's in the capillaries that this asphyxia happens. And here it is. This shows oxygen here. When the person takes a deep breath, the oxygen will go up. And that proves that they've got the capability of breathing it in. It's not something that they're limited there. This is the carbon dioxide. And really, the oxygen levels should be up here and the CO2 down here somewhere. So this is just an illustration from one of the patients of what we're finding. So now we can talk about sleep, and I'm going to run through this fairly quickly. Because of time, I would like to illustrate my talk with the patient studies. Conservation of energy. The metabolic rate is reduced at night, and particularly during sleep, by 5 to 25%. Oxygen consumption, heart rate, and body temperature decline during the first few hours of sleep, which is the time when we have slow wave sleep happening. And so we've been looking at sleep in our patients. And here we are. When you're awake, this is the sort of electroencephalogram. I don't think I need go through all this to you, except to say that we have to go through this rapid eye movement phase of sleep. And what we do in our patients is we just have them sleep deprived, which is quite easy for them. They arrive in the morning and we connect them to the equipment and put a little cap on, and we find that we can do the evaluations for them within a few hours in the morning. What we find is that they go through this and then they're aroused and they go back again, and then they go down and they go back again, and they have all these alert arousals and not enough REM sleep. So the whole body gets restored in sleep. Growth hormone is released then, and we have to have proper macromolecular synthesis during slow wave sleep. And during REM sleep, they think that this is when neuronal connections are formed, and this is necessary for proper cognitive functioning. So this is fundamental. So each sleep cycle, each sleep cycle is important. We go through three of these at night, usually 3 or 4 at night. Lots of hypnotic drugs reduce the proportion of REM sleep, and they relax the muscles at the back of the throat so people begin to snore. So really people should have no alcohol in the evening, no caffeine for 6 hours, no hypnotics if they're apneic or hypopneic. That means they're not breathing properly at night. Because all hypnotic drugs reduce the proportion of REM sleep. So what we know in people who have sleep disorders, sleep apnea, they have all these symptoms. And does this sound familiar? These are all things that we see in fatigue states. And hypopnea is the same, tiredness and irritability and all this, and fatigue. But unfortunately, in some, there's also the liability to road traffic accidents and so on. If people are doing this without the full spectrum of chronic fatigue disease, but they've got apnea, they'll be still driving and they're at risk. So there are standard evaluations for sleep disorders, obstructive sleep apnea, when the muscles at the back of the throat are lax and the large tonsils or a small jaw, or obesity, diminished thyroid function, nasal problems, very deep sleep, and obstructive sleep apnea. Symptoms are snoring, excessive daytime sleepiness, and sleepiness is not the same as fatigue. So there are overlaps between this and fatigue states that we know of. Morning headaches, night sweats. And the management is to treat the underlying endocrine problems and to do weight loss programs and posture training, breathing exercises, and all these things. But also, in our patients, they have central sleep apnea, which is not obstruction only. And this is sleep-disordered breathing, where the central control of breathing is out of order. And again, we get carbon dioxide levels rising and oxygenation reducing. And this, of course, happening at night is a bigger risk for those who are already asphyxiated in the day. So we use machines to give people oxygen. So we do polygraphic studies with breathing assessments with a nasal thermistor and EMG and EEG and an electroencephalogram. And I won't go through all this. These are right and left sides of the brain, but at the bottom you can see here somebody breathing away. Then they fall asleep, and you can know this because there's sort of synchronous sleep waves here. And look, no breathing at all. Look, there's a little sort of trial at the breath there, and then nothing for minutes at a time. So I've just picked out this one, and that's when the person's asleep. And they can't stay asleep and not breathing, and the body sort of thinks, I've got to do something about this, and there's a state of arousal that happens, and they wake up a little bit, so they never go into deep sleep. Things are not restored. So there we are with the arousal and all this breathing again, and then it'll all happen again. So pain, just to say that we do also measure pain in our patients if we can. Dull, slow pain, they have flu-like symptoms, sharp, fast pain, shooting quality, and we can measure this by single fibre evaluations in the tissues. And we use membrane stabilizers, which are both gabapentin and pregabalin. In the gut, we use nalcrom, Intel for the lungs, opticrom for the eyes, rhinocrom for the nose. These are all membrane stabilizers. But the stalwart part of our treatment is low-dose immunotherapy, because it also can, in some people, reverse some of the dysautonomia that we see, and certainly stops them having inflammatory reactions from foods. So I don't think I've got a lot of time, so what I'm going to do is to just talk about supersensitivity to food, perfume, chemicals, and stroboscopic light in migraine. It mimics what goes on in people with fatigue states. Epilepsy, again, it's a supersensitive state. Encephalitis, sound hyperacusis, photophobia, encephalitis from organisms, and encephalopathy with disruption of CO2O2, the sleep center, and from foods and pollutants. This is just to say that we always look at Lyme, and many of our patients have got Lyme borreliosis or its cofactors. The fourth in the squares that I went through is to do with food sensitivities, because our patients develop food sensitivities. It may be secondary to the viruses that are in the gut lining, and I think it's very commonly so, and chemical sensitivities. We use low-dose immunotherapy. Oral tolerance to dietary antigens is maintained by different mechanisms: anergy, cell deletion, and immune suppression. But in the presence of mechanical or chemical stressors and infections, this tolerance breaks down, and we have the reactions to different luminal antigens, particularly with production of cytokines, opening up the tight junctions between these cells. Lots of undigested antigens get through the gut lining. We get bacterial and candida into the circulation, and we can measure this because we see the antibodies, and we can measure the antibodies. Now, just to mention, tissue transglutaminase is an enzyme that deamidates or removes an amino group from gliadin, which is the protein from gluten. And then it adds the remainder of the peptide onto existing proteins as part of a normal repair process. This can, in celiac disease, complex with gliadin, which forms a new antigen, and this is processed by the cells which form part of the immune surveillance system, and they can actually kill the mucosal epithelial cells. But you can get this in the absence of an enteropathy, because we also find that in many of the patients we've got antibodies to gluten or gliadin, and we have lots of antibodies to other tissues everywhere else in the body, the gut, the joints, the nervous system, the thyroid. So I think gliadin peptide can be doing cross reactions, and it can breach people's gut and cause loss of tolerance. And you get a lot of barrier dysfunction from viruses as well, particularly rotaviruses, very, very common. I mean, this is known. It's probably also so with Coxsackie. So this rotavirus peptide binds to gliadin peptides, and it also is recognized the endomysial structure and can activate it can alter the permeability of the gut. It also shares homology with other self-antigens such as heat shock protein and various other substances. And it's gluten sensitivity is always associated with an increase in intestinal permeability. I've focused on gluten because it is one of the things I think people should stay off when they're in acute phases of their illness and when they're having early treatments. Because of the prevalence of it, it's 1 in 100 for one patient who's symptomatic. There are 8 patients with no GI symptoms. 10% of the healthy population have elevated gliadin antibodies. And when we've tested against lots of different antigens to joints and so on, we get antibodies against one or all of these organ-specific antigens in these patients. So we use low-dose immunotherapy. We use doses here, here, or here. We don't go for higher up. We prefer these to block reactions. I was going to mention case histories. I don't think I have time to do them all, but just to do a very quick illustration of a lady, 28, with fatigue. She had tonsillitis. Oh, a gentleman, I beg your pardon, with fatigue. He worked in a nightclub and was drinking a lot. He was very ill. He had lots of autonomic symptoms. He was totally... he had all the symptoms that people with chronic fatigue have. But he had abnormal mitochondrial function, gut dysbiosis, very high levels of toxic metals, and we actually did autonomic tests. He had hypercapnia. His CO2 was 47. His oxygen was only about 18. And we did chelation, breathing exercise, nutrients to support him. Then we got more history from him as he was giving us more history as we went, and we found that he'd been wood stripping and waxing floors for 9 months. So we did a hyperthermia, and then we did repeat autonomic tests, and they were normal. So we've now got him on graded exercise therapy. So this one is aged 60 with eczema and asthma since the age of 30. She came to Breakspear years ago, 20 years ago, and she had her eczema managed with low-dose immunotherapy. She had fatigue developing at the age of 50, and she presented to us 5 years after that with swollen joints, and she began to have seizures. She was intolerant of drugs. She had an elevated ESR and CRP, rheumatoid factor, positive Borrelia, Western blot, positive serology for Babesia. She had a gut dysbiosis. She was treated with IV ceftriaxone and pulsed oral antibiotics for 3 months, and she had low-dose immunotherapy. Her joints have improved, and after 8 months she's able to garden and work again. She's an acupuncturist, so she needed her hands. She continues with her low-dose immunotherapy and phytonutrients. And have I got time for 2 more or not? 1 minute, yes, okay. 50 years old, joint pains and swelling as a child. She was allergic to animals, only able to manage a few foods. When she was 20, fatigue. Age 30, SLE, improved with changing her diet, excluding grains, having B12 injections. Still complained of fatigue, joint pain and brain fog. Poor mitochondrial function, elevated lead and mercury, metal retention, multiple food allergies. She had IgM antibodies to lots of stealth organisms, and she was treated with low-dose immunotherapy. She had chelation, continued having problems. Then we found she had outer surface protein antibodies for Borrelia. She had oral antibiotics, no response, IV antibiotics. Her fatigue improved. She still had cognitive dysfunction. Then we found, they looked at her transcutaneous gases, low PO2, low CO2, both, low cardiac vagal tone. So we started to use oxygen, 4 litres per minute. And she is now able to run her household, but I still think that, she's got a way to go. Yes, same person, periods of apnea. She has the BiPAP machine now. She's sleeping well, no further awakenings at night. You see, if we can get the night together, the people are better. and her energy and cognitive function are improving, so she's doing much more. And a last one, 77-year-old lady with fatigue, migraine, hypertension, increasing muscle pain affecting her arms and shoulders. She had an MI 2 years ago. High ESR, multiple B vitamin mineral deficiencies, IgG antibodies to foods. She had Linde in her translocator sites. High fibrinogen, D-dimers, thrombin, antithrombin complexes and prothrombin, so she had no circulation through her capillaries. We gave her low-dose immunotherapy, B12, anticoagulants, and we gave her a short course of oral steroids. And she's improved, but she still had a possible fit. We had seizures excluded on EEG. Sleep EEG showed long periods of apnea. And so what we're doing now is treating her with oxygen as well. She's 77. She's doing very well. She's had a winner recently in a horse show. So I thank you so much. That's very kind of you to have invited me.